Welcome.
Thank you, John.
I should say to everybody, you will have this experience in life where you work with a professional colleague, and you see that where they're going is somewhere way beyond where they are at the moment. And when we first met, he was the director of the Global Health Institute at Harvard, but he was so interested in public service. I knew that the day would come. I didn't know it would be COVID, thank God. God forbid. But I think the way you have combined an academic career and a career in public service has been really exemplary for all of us. So thank you. And thanks for being here at Georgetown. So, for no surprise to everyone here, but I'll start with a question. So where did it all begin? Where did you grow up? And what got you interested in the kind of work that's been the passion of your life?
Wow. So I'll give you the quick sort of life story. I was born in India. I was born in Bihar, which is a poor part of Northeast India. My parents moved to Canada initially when I was 9. And they moved for the reasons that people in lots of places move to Canada and the US, right? It was sort of give their kids an opportunity for something very different. I went to school in Canada till I was 14. So I showed up to Canada not knowing any English.
Wow.
Learned English in Canada, learned to love the Toronto Blue Jays. I'm a Red Sox fan now, I will say.
So eventually it happened, right?
And moved to the US when I was 14. Went to high school in New Jersey, college at Columbia in New York City. And at Columbia, got super interested in human rights, ran the human rights organization there for several years, got interested in, kind of thinking about how do you make change in the world. Right. I was an econ major and got dissuaded from going into economics by one of my economics professors who said, if you're going to do economics, it's mostly just math. And the moment you put an equation on the board, you lose 95% of humanity. So he's like, if you really want to change the world, economics is not the way to go. I actually think that was probably not the right advice.
It's exactly.
There's economists who've made massive impact on the world. But anyway. And then I will be honest, and I think I'm now old enough that I can just go ahead and admit it. Yep. I went to medical school for all the reasons you're not supposed to go to medical school. I went to medical school because my parents really wanted me to go to medical school.
I got you. I was wondering.
So, it was a very classic Indian thing. It's not only Indian, other cultures have this too, but for my parents, it was very important that they had 2 sons, my older brother and I, that one of us become a doctor. My older brother had 0 interest. And so it was me or bust. And I felt, and this is interesting because I think it shaped a lot of my thinking, I felt as a kid of immigrant parents who had given up their entire lives in India to come and struggle in the US, this sense of moral obligation of I owed it to them.
Interesting.
Sort of interesting.
Yeah.
So I went to med school at Harvard, and this is, and what I'm about to say next is an issue that comes up a lot in my life. I ended up loving medicine. I ended up loving medical school and can't think of a career that would have made me happier. And I often wonder, did I get lucky? Am I just somebody who has this incredible bias towards liking what I'm doing?
Right.
There's probably an element of that, but it's probably a bit of both. And then while I was in medical school, all the sort of interests in human rights and policy and economics sort of stayed with me. So I took some time off. I did research. I got involved in a lot of kind of campus activities in medical school, thinking about combining medicine with something else. Mm-hmm. What that something else was never totally clear. And I started taking a lot of classes at the public health school as a med student, partly because it was really clear to me that, see people in clinic as a second or a third year student, and you had a sense that you were sort of patching up and putting Band-Aids on these massive problems people had in their lives. So you saw a homeless person who came in with a medical problem. You could fix the medical problem. You could give that person medicines. But the notion of okay, here's a pill you should take 3 times a day.
Right.
That's really hard for someone like me in my life. A homeless person taking a pill 3 times a day, like,
Right.
where are they going to store it? How are they going to remember? They're moving. So it just started becoming really clear to me that like moving people's lives in the right direction really required a much broader set of thinking than what I could do from a clinic or from a hospital. And I think that was sort of the beginning of my interest in public health.
Interesting. Okay.
And then I'll just finish off this part by saying, and then I, after medical school, went to California, did my residency training at UCSF, which was fabulous, and came back to Boston for a research fellowship, and the rest is sort of, I'm happy to go wherever you want, but but that's the
Well,
that's the trajectory.
before we jump to get to your work when you get back to Boston and at Harvard, I'd like to go back, if you don't mind, to the question about doing what your parents asked.
Yeah.
Because it makes total sense, right?
Yeah.
I mean, and I suspect it's true for other students with immigrant families, but also with just families where parents care a lot. But did you have a sense that, I mean, so many undergrads think about science. It's like do I like it enough to? Did you have some love there where it wasn't like, you know, you were at the crossroads and you wanted to go one way, and it sounds like you were open to it.
Yeah, I was a pre-med.
It's how to be open, I guess.
I was a pre-med in college to keep that as an option. I did my econ major. I guess the thing that I always felt, I liked science fine. I thought science was interesting. It was fine. But I had zero interest in having a scientific career. Like, I would have never gotten a PhD in biology.
Gotcha.
Because for me, even from the early days of college, it was always about the application. It was always about how do you use a set of tools you've developed to change the world. Right. And again, it is not to say that a biologist can't do that. In fact, great biological discoveries have changed the world.
Right.
So, but it is a different path into changing the world. And that was just something I knew about myself, that I needed a more direct application.
Yeah.
So if I was going to go do something in the sciences, it would have to be in the service of something else.
Gotcha.
Medicine felt like that.
That was the way. And then to fast forward ahead, I just think it's fascinating. I mean, you were really raised in 3 countries. Obviously, Canada and the United States are similar in some ways, but more distinct than others. Yeah. I guess your reflections on how that made you feel. You got to Columbia, I mean, a terrific university in the heart of New York City.
Yeah.
But what did you think you brought from those experiences of growing up? It's been key parts of your life in very, very different places.
It's a really good question. And I don't know that I've thought about this in this way, John. Columbia was an interesting place, and it was transformative for me. It was probably the 4 most transformative years of my life, and I'm happy to explain why. But one of the things about Columbia is being in the heart of New York City. It created one of 2 reactions in most of the students. One group of students felt totally fish out of water, uncomfortable. You're in the middle of Manhattan. And Manhattan, for a lot of people, is a fun place to visit, but I don't know if I want to live there, kind of thing, right? That was one set of reactions. Or for another group of people, it was I finally found home. Right. And I had that second reaction, and I don't know that going into college I would have predicted that. But I think the various backgrounds of having lived in India, having lived in Canada, having lived in the suburbs of New Jersey, I found in New York and Columbia, but New York more broadly, this crazy diversity where I felt like I didn't have to slot myself in. The fact that I was many things was fine.
Right.
Whereas I think in a lot of other places you would have to say, well, what are you? Are you from New Jersey? Are you Canadian? Are you really Indian? Nobody cared in New York because everybody was just sort of like something.
Yep.
And that made it easier for me to feel like I belonged. And then the other thing, and it's a little personal, but I think it goes along with the theme here. The other thing I really struggled with in the early days of college and found a mentor who helped me through it was the issue of identity. So I was born in India. I thought of myself as an Indian kid. I spoke Hindi at home with my parents. My parents had a set of expectations, including that I would go to medical school. But I also felt deeply American, right? and Canadian American, whatever,
Sure.
right? I had lived now, if I came at 9, I was now 18. I had lived a majority of my life here. And I always sort of felt like there was a tension between the two. And I met a guy named Michael Paley. He was Rabbi Michael Paley. He was the head of the chaplaincy at Columbia. And he became, I would say, my closest mentor, advisor, friend, guide. And he talked about his own journey growing up as a, obviously, Jewish kid in Brooklyn in a neighborhood that was like 98% African American and struggling with his identity of, is he a Brooklynite? Is he Jewish? And talking about how America allowed you to have multiple identities at the same time and do it in a way that you could be authentic in both. That I didn't actually have to choose between being Indian and being American.
Wow.
And that was profound for me because I always was like, I don't know how I'm going to choose, right? And Michael Paley was the first guy who kind of gave me permission to not choose. And I think it was transformative. It has allowed me to feel very deeply connected to India. I was in India a couple of months ago, felt very much like it was a homecoming. And yet I'm obviously deeply American.
Right.
And I think this is a country that allows that. And I think there are a lot of people who want to push you into what identity are you.
Sure.
And, for me at Columbia, at least, I learned that I could be multiple things and be authentic in all of them.
Well, I usually try to go chronologically, but that comment kind of requires me to go to our current political moment.
Sure.
Because I do think, at least in my life, and I had a very different experience growing up. I grew up in the same neighborhood on the northwest side of Chicago. Everybody looked like me. Everybody went to the Catholic Church was over. We were a very it was a homogeneous community. But of course, the world, once you leave that world, then you realize what the power of America. And I guess I'd love, without losing too much of the chronology, we are in a moment where some people are openly and explicitly arguing that that's not what America is, that you can't have multiple identities.
Yeah.
And it seems to me it's a contested idea. If we'd done this conversation 10 years ago, I don't know how contested it would be. So I guess I'd love your thoughts when you look at today's political culture.
Yeah.
And do you think that sense of home you had is no longer part of our political, or at least there's a big part of our political dialogue that doesn't see that?
I think I want to explore that question with you, but I'm wondering if you can go one step more because there are a couple of different ways I can interpret that question.
Sure.
So how do you see that shift? Is it just say more?
I just think that there's a set of people who believe that you're either American, and that can be defined like how they see it.
Yeah.
And I don't think it's just a Trump or it's not a red blue thing.
Yeah, because that's what I'm saying. I don't know that it's left right.
But I do think it is visible now in a way that is very acute, probably because of the politics of our moment. And I guess it's the power of the multiple identity experience that I think is really a direct challenge to the idea that we can be clear about it.
Yes.
And so I'm not talking, it's not just left, right. You're exactly right. And I didn't mean, but it just seems to me we're in a moment now where that idea of being an American with multiple identities is contested. It's contested publicly in a way that we haven't had for a long time.
Yeah, so there are two ways I interpret that question. I'm actually going to try to maybe think about both of them out loud. One is there is a very pernicious, just blatantly racist set of views of what an American looks like, and that set of views has always existed but has been below the surface. Right. And I think in the last 10 years it is no longer below the surface. Right? So you have people who are just openly saying we have too many Asians or too many black people or too many Latinos or too many whatever, pick your group, in these positions. That is a very troubling small minority, but vocal. And I guess, I don't know if it's much bigger than it was, but it's way more visible.
Well, visible. That's
a problem. There is a different identity issue, which is that a desire to quickly categorize everybody into a bucket. Yep. And that has its own real deep problems. Because fundamentally, the fracturing kind of America that we are seeing is our inability to find common ground and common identity, right? So you all can look at me, say, Indian American, kind of in the Asian category. He's a man. You don't know my sexual orientation, but you might, but that could be one other identity. Elite, has spent much of his life at elite institutions. Upper middle class, maybe even wealthy, I don't know, but you got some categories. And that whole thing puts you in one bucket. And it separates you from large chunks of America. And people try to do that kind of thing. The problem with that is, so my wife is from rural Ohio. And we spend lots of time with her family. They all voted for Trump, like every one of them. And they are extraordinarily kind, thoughtful, generous, loving people. They are to me.
Yeah.
Like an Indian American guy who, is an immigrant. Have never felt an ounce of hostility from any of them. And I relate to them really well. And they relate to me. They think I'm a little kooky in some of my views. I think they're kooky in some of their views. Right. But if we can't find common ground because of our identities, then we have no ability to have any kind of a shared vision of what America needs to be. And so I think there's also this desire to bucket people into buckets that fractures us. Yep. And I have always lived multiple identities. And therefore, I bristle at any effort to put me in a box. People are like, oh, you sort of have had this privileged elite life. I'm like, actually, I've not had a super privileged life. And I'm not, and I feel very comfortable. So I think it's really important for us to see the multitudes in people and not try to bucket people too much into one set of identities, because it actually harms us as a country. And I think it's part of what has made it so much harder for us to find common ground on this.
That's a great answer, because I think you really did identify two different streams in our current politics that are unhelpful.
Yeah.
I mean, obviously there's one that has been ancient and sort of consistent, but definitely visible. And at the same time, this bucket issue. And so the reason I mention it is that because it just seems to me comfort with multiple identities is an American project.
Yes.
Just by our nature.
Yes.
It's also, in many ways, a public health project.
Yes.
Because if you're not, we have to think about, public health is fundamentally about communities, and all kinds of communities. So maybe if we travel back to the chronology.
Yeah.
So you're back in Boston. You finished your residency, and now you're thinking about what to do with this career. And you practiced medicine, and you got involved in public health. I'd love to hear more about, as you saw, integrating a career that had both the direct service and public.
Yeah. So I have continued practicing, and actually I sort of stopped about 1.5 years ago, but made the decision to go back. So I'm going to start back up on clinical service again in a few months. I had to stop when I went to the White House for like 18 reasons. I had to stop, So first question is why do the clinical stuff? And in my mind, there are 2 or 3 reasons. One is it's a set of skills I've actually spent a lot of time honing, and I feel like it's a useful skill. Second, it gives me a level of personal satisfaction that nothing else I do does. It is a remarkable thing to walk into a patient's room, figure out they are really miserable, figure out what's wrong with them, start a treatment, and 24 hours later, they're dramatically better. That just is amazing. Very little that we do in our lives has that kind of direct impact. The third is it grounds me in all of the thinking I do about policy, right? So I do a lot of work on thinking about healthcare quality and costs and structure of systems, and think about long-term care and how should it be organized. And then I have a patient in the hospital and I'm trying to get them to a nursing home, and I can't. And I'm like, oh yeah, this is where the rubber meets the road of policy. So it grounds my thinking about policy, makes it real, personally satisfying. And so that's why that has always sort of remained a part of what I do. But just by the nature of sort of my thinking about stuff, I don't think I could have been a full-time clinician.
Okay.
Partly because of what I brought up earlier, of I wanted that broader perspective and wanted to work on those things. I also think it's really fun to like try to use research and advocacy and policy to try to drive systemic change. And when it happens, you see big impacts. And, think about something like the Affordable Care Act. Because of it, 25, 30 million Americans have health insurance that would not.
Yep.
Not as much as we had hoped,
But a lot.
but 30 million Americans have health insurance who would not.
Yep.
And that's systemic change. And you can't do that being a clinician, one patient at a time.
You can't see 30 million patients.
No.
Exactly.
And when you're trying to make change at that level, unless your name is Barack Obama, no one person gets to drive that entire change. It's hundreds and hundreds and hundreds of people's research, policy, advocacy, but all coming together at a critical moment with the right leader, and boom, you get across the finish line. So systemic change happens, it's big, it's unpredictable, it takes years, but boy, when it happens, it feels good. So, and so I've kind of loved both of those things, and I have always felt like they're very complementary because you can do both. And by the way, just as it grounds my thinking when I'm in the hospital, a lot of times I'm in policy conversations and people are coming up with ideas and I'm like, yeah, that'll never work. And people will be like, why? I'm like, let me tell you how doctors are going to manage that.
Right.
Because I know a lot of it.
Right.
And so it also grounds, so there's a bit of back and forth between the policy work and the clinical work.
So moving forward, though, I mean, I guess before you joined the White House, you led a global health initiative at Harvard, but you stayed in academia and tried to influence from the outside. So I guess any thoughts you had about, I get the pull between the clinical and the policy, but you were trying to use the power of your work and universities to change policy from the outside. I guess I'd love some thoughts on that before we turn to your time in the White House.
Yeah.
How do you be an advocate? Because you're an advocate, fundamentally.
I'm an advocate for using evidence to make policy, right? And so there are a couple of different types of advocates who influence policy. And the way I look at it, and having now been on the other side, seeing it, there are times when, as a policy person on the inside, I was pretty sure I knew what the right answer was, or I'd made a decision. And then I often looked for advocates to help back that. There were other times, plenty of other times, where I didn't know what the right answer was. And I almost never looked for advocates at that point. I looked for scientists to help me figure out what the right answer was, right? And you, as a policymaker, you deal with both. So I think it would have been hard for anybody to know, like, what was I advocating for? Because, so for instance, like I had principles, like I believe that everybody should get covered. I believe that healthcare should be more efficient and higher quality. But then, like, who in this room does not think healthcare should be higher quality and more efficient? So my advocacy positions were rarely like Medicare for all or, right? And so what happened, and this often pained me, is the most consequential health policy act since Medicare and Medicaid was the Affordable Care Act. The ACA was essentially two bills in one, the things that did insurance coverage, and then a whole bunch of efforts to reform the healthcare delivery system, cost, quality. And I was a cost and quality guy. It was most of my research. And so I spent the first 5 years, 6 years after the ACA was passed, essentially assessing the impact of the ACA on the cost and quality stuff. And it pains me to say that most of the data suggested it wasn't doing much on cost and quality. And that was painful because I had a lot of friends who were in the administration.
Yeah.
And a lot of people who were like, why are you so down on this? And I had a friend, a really good friend, who one day I published a paper in JAMA, essentially showing like one of the main provisions of it hadn't worked. And he called me and he's like, this paper really pisses me off. And I was trying to talk him through it. And he said, you just have to decide which team are you on.
Interesting. So what did you think? Which team?
And I said, with all due respect, my friend, I think you misunderstand my job. I am not on the like the Democratic versus the Republican team. I mean, my views and values are pretty clear, but I think the country needs scientists who can objectively evaluate policy. And if it's not working, say it's not working.
Right.
And if that puts me on the wrong team, and he's like, oh, you're so naive. You know that's not how Washington works. I said, I understand that Washington works in different ways. And it is fine if you think that I'm like playing this wrong. But for me, the issue is, I feel like I got to be the honest broker who can do the honest evaluation of the policy. And if that shows that the ACA's provision didn't work or was harmful, you bet I'm going to publish that. But that is hard.
Yep.
That is hard when you think of this as a team sport. And so I tried to be, and I think even in the pandemic, but certainly before the pandemic, be seen as an honest broker who would call it as I would see it, and did not want to be pinned down as I'm pro X or anti Y. But that meant at times I had lots of friends, and at times I felt like I was very lonely.
Just part of the deal.
It was part of the deal.
So let's fast forward. President Biden asked you to come and help on the biggest public health calamity in a century. And to take a leadership coordinating role. And then all of a sudden, you are on a team. You're working for someone who got elected and wears a colored jersey.
Yes.
And how did it feel as you transitioned? Was there any sort of, how did you navigate that? Because there are different roles, and everyone understands that. But you're the same person.
Yeah.
You've just played you're playing two different roles.
Yeah, and can I tell you a little bit of a lead up to that?
Sure.
So I had been pretty consistent in my messaging about how we should manage the pandemic, really since March, April of 2020. And in the first 4 or 5 months of the pandemic, I was all about we got to get testing up and running and make it widely available. And so President Trump's testing czar, Brett Giroir, and I would just go at it publicly. And he was very critical of me, and I was very critical of the administration. And it wasn't personal. I just thought they should fix this. And when President Biden got elected and then got into office, obviously initially things started looking better. I was speaking much more on kind of behind the scenes, saying you guys got to do more on testing. And as 2021 wore on and the summer and fall came, I started getting more publicly critical of the Biden administration about their testing stuff and a few other things, but primarily around their testing stuff. So it is March of 2022, and I am sitting. So my interview with the president was not actually in the Oval Office because they did not want me going to the Oval because they thought if people see you, people recognize you. So we met in the East Wing in the treaty room where this treaty for Alaska was signed. But I'm sitting next to the president, and he starts off. He says, "Well, what do you think that we've done well as an administration on COVID?" So I talk about a bunch of things, and he says, "What do you think we have done less well?" And I started by saying, I think the administration strategy on testing has been a real problem. And he smiled and he said, "And you've been very critical of us publicly." And I said, "I'm sorry." He said, No, we should have done better.
Fair.
And the point of bringing up that story is, it's very painful if you're sitting next to the president, somebody you actually respect, to first of all criticize what they've done, and for him to say, "Yeah, and you've been pretty tough on us on that," right? Because it is a team sport.
It is, yeah.
And he's asking you to come join the team. And it's hard to have someone who's been beaten up on the team.
Right.
It's interesting because in my vetting, there were very few concerns about some dark secret in my past. My life has been actually turns out to be pretty boring. Almost all the concerns were, how have I been critical of the administration? And I realized once I got in that I was part of a team. And when you're a member of the team, there's some upsides and downsides, right? So the upsides are, If I think that testing is a problem and we have not fixed it, I actually get to fix it.
Right.
I don't have to criticize anybody else.
Right.
So that's fun. But it turns out that you won't be surprised that the COVID response coordinator at the White House is not the final decider on everything. There are times when there are people above you, and they're, the chief of staff or the president, who want to go in a different direction on an issue. And because you're a member of a team, you shut up and you're on the field. And the trade-off of I get to actually call a lot of plays, but there's sometimes the coach or will overrule me. You just gotta
run the play. The coach sends in, right? Okay.
And the reason that's important, it's not like it's a sacrifice, actually. What you realize is they're playing a different game. I am there to deal with COVID. They're there to run a country. And 90% of the times, we're aligned. Better manage COVID, better for the country. 10% of the times, there's a broader policy, political interest, which means that what you want to do on COVID is not going to get done.
Right.
And it makes all the sense in the world. There's an analogy, there's a version of this I want to just quickly mention in a second. And you just realize that's fine. Like, that's how democracies work, that's how governments work. I was reminded of as I was speaking, in the fall of 2020. So during 2020, what happened was, there was in many ways a kind of a collapse of the federal government's response to the pandemic. You may be surprised to hear this. Donald Trump was not a very effective president in terms of running the agencies. And what that meant was that governors felt totally lost. They couldn't get advice from CDC. They couldn't get advice from anybody inside the federal government. They would call CDC and they get one piece of advice. They'd call someone at the coronavirus task force, they get opposite advice. They'd call someone at ASPR and they'd get a third advice. And they were like, what is happening? And so they started reaching out to trusted academic experts. So I ended up advising about a dozen states. Some of them, I was on the phone with their health leader or their governor 4 times a week, and others, it was like every other week. And I remember a Zoom call with a governor during a very bad outbreak that was happening, and hospitals were in bad shape. And this governor, it's a Sunday morning, like 7:30, we're on a Zoom call, and the governor says to me, what do you think we should be doing? And I started off by saying, Governor, like, the first thing is, given how bad your numbers are, you gotta shut down bars. Your bars are still open, and bars are like the ultimate place to be spreading this virus, and you gotta shut down bars. And again, on a Zoom call, I see the person's face, and the governor says, okay, what else you got for me? And that was the moment I realized, not doing that.
Right.
I was like, okay. And I went through and I had 4 other ideas. The governor thought 2 of those 5 ideas were interesting. Ended up doing 1 of the 5.
Okay.
Victory. And if I had taken that moment and taken it personally or been upset or said the governor's getting it wrong, I would have totally misread my role. I reminded myself, no one elected me anything. I was not the governor of that state. I had 0 accountability to the people of that state. And if I screwed up, no one could hold me accountable. Right. The person who had been accountable, if you believe in democracy, which I do, the person who had been elected was going to make a set of decisions. And this person was going to take in a lot of factors. I was happy to be part of that conversation, but I was not the decider. And so this whole thing of like, you got to listen to the science, be driven by the science. Science has got to be a part of the conversation.
Right.
But it can't be the final driver. We're in way too complex of a society.
Right.
And I think that it was moments like that that just reminded me that people are like, oh, the politics is overriding the decision. I'm like, the politics should override the decision.
Right. Because that's why you elect people.
That's why you elect people. Because politics is not a dirty word. It is how you work out competing interests in a complex society. And that is what the political process is. And the alternative to politics is dictatorship. And, and so anyway, just was an interesting
So
realization.
this will be my last question before I ask Hannah to kick us off
Yep.
here, but it flows from your last comment.
Yeah.
The other thing that I think you are exceptionally gifted at is being a public communicator about science and health. And you're all going to be lucky. I hate to say this, you're still number 2 on my list. Number 1, Dr. Fauci, will be with us later.
I was going to say, he's like one floor down.
Yes, exactly. But
He is the best.
But you are fabulous, and you've done it both as for NBC, but most powerfully, I think, for the White House. And I guess I'd love your thoughts about how should, now that we've learned so much about communications and public health, how should public health be communicated effectively to a country as big and diverse as ours, and recognizing our role really to a world that's even bigger? But
Yeah.
I guess it feels to me like we all agree that a lot of mistakes were made along the way, and how we've communicated, and especially somebody with your scientific knowledge, what's your role as a communicator? How do you navigate that?
So one bit of information. So I didn't actually sign up with any network.
Oh, I'm sorry.
No, it's fine. And the issue, I bring that up for a reason, not to correct, but to say, I did a tremendous amount of conservative media. And in the 6 months before I went to the White House, the media that I did probably more than any other, the channel I did more than any other, is Newsmax. You guys know Newsmax? Newsmax, I always say, makes Fox News look like MSNBC.
Right.
Right. Newsmax is way to the right of Fox News. They have some crazy people on there. I shouldn't say that. They're lovely people. I was doing Newsmax 3 to 4 times a week.
Huh?
And as soon as I went to the White House, they put a stop to that.
Right.
They're like, because now you're in a team sport.
Right, exactly.
And the rule I had in my head was you should be able to watch me on Newsmax, and you should be able to watch me on MSNBC, and everything in between, and you should say it's the same guy. Maybe he's describing things a little bit differently, but it's the same guy. And I had sort of 2 or 3 approaches to this. And I'll give you an example.
Yeah, please.
So I was on Newsmax, and what they would do typically, they'd bring me on, a little bit of banter, then they would play a clip of some kind. Essentially trying to kind of goad me into it. It's a very fun game because they kept bringing me back, and so they play a clip of Governor DeSantis from Florida. I assume everybody knows who Ron DeSantis is. And Governor DeSantis is talking about masks in schools. This was at a time when masking in school was still pretty prominent. I was very supportive of masks in schools. He plays a thing, and he says, this is about government bureaucrats telling parents how to raise their children. Government bureaucrats should not be telling parents how to raise their children. I think this is a parental decision. If parents want to mask their kids, that's fine. But we're not going to have federal bureaucrats telling us how to raise our kids. That's the clip. Cuts to me. Dr. Jha, do you think federal bureaucrats should be raising your children? Now, that's a heck of a way to frame that.
Right.
So my response was, I said, look, I'm a dad. I've got kids in public schools. I obviously care deeply about shaping the experience that my children have. But I live in a community, and I have responsibilities. I can't send my kids to school naked. There are rules against that. Right. My kids have to be vaccinated against polio. It's a responsibility of a community. I do it for my neighbors. I do it for the kid down the street who may be immunocompromised. We all do these things living in a community. This is, to me, not about federal bureaucrats or state bureaucrats. This is about what is our responsibility to each other. And I think it is totally reasonable for communities to make a decision that that's the way to protect themselves. And I don't know, that seems pretty American to me. So it was, now the language I was using, communities, I didn't talk about governments.
Right.
I talked about being very American.
Right.
I'm not sure I would have used exactly the same words on MSNBC, but they wouldn't have framed it in the same way either.
Right.
So some of the language was a little different. But I would do 2 or 3 things in each of these things. First, I would try to personalize it.
Right.
right? So it wasn't like the scientist is telling you. It was, I am a dad. I have kids in public school.
Right.
So I get the issue, right? And the same thing, when people bring up vaccines and what about, and I'd be like, look, here's how I'm doing it in my family.
Mm-hmm.
Reminding people, I'm living in this pandemic too, people. I have the same set of questions that everybody else has. So one was personalizing it. The second was avoiding jargon at all costs. Mm-hmm. Because scientists love to fall back on jargon. And it's a shorthand, but it's actually alienating. And the last thing that I always did was I tried to think about the person who was watching as my mother. So my mom, I'll tell you a little bit about my mom. My mom was a public school teacher in New York City for 25 years. And my mom is very smart. She has zero background in medicine and public health. She always wanted a son in medicine, but otherwise no interest in it. And I don't know if she would ever watch me on Newsmax, but she would watch me on other things, because often I would tell her it's CNN in 10 minutes, right? So she'd turn it on. And so I always knew that my mother was watching. And my goal was, I'm going to speak to my mother and answer the question to my mother.
Right.
And it was a way of focusing. You're trying to talk to someone who's smart. I never talk down to my mother, because that would be a bad idea, right? So you're not going to be paternalistic to your mother. You're going to treat her with respect. You're not going to use jargon, and you're going to speak plainly. And that was the strategy. I wonder what Tony's is. Tony's brilliant at this. But I also tried, whenever possible, to personalize it, because I thought it just helped people humanize me, and then kind of therefore be more open to the response.
I think that's terrific, because I do feel like we have to reconsider if we're going to be ready to communicate for the next event, whenever it comes.
Yeah.
How we talk to people, because we're all in this community.
Yeah.
So I'm going to transition now to the part where I open up to questions from the class. And Hannah, who did the briefing, I would ask you to kick us off tonight with a question.
Yeah, thank you so much. That was very interesting. I have a question sort of about, I think we can all agree that the public trust in public health has significantly declined, especially since COVID. So moving forward, how do you think that can be rebuilt, and who do you think that burden sort of falls on? I guess it's probably spread out, but.
It is spread out. It's a really good question. I wish I had a simple answer. I don't. I think, when I think about why that trust has been eroded, I think there are two sets of factors. Let's be very honest, there's a lot of people who have used every misstep of public health to undermine confidence in public health. I think there are a lot of bad actors who continue to do that. I also think there have been a lot of missteps inside public health. And I always sort of say to my friends who point to the bad actors who misuse our information look, I can't control them. I really can't. But we got to do better ourselves. Public health got a lot of stuff wrong. I have tried very openly when issues have come up to say, I was wrong on this. Or I really thought, it is true. In February of 2021, if you asked me whether we were going to see waning immunity after vaccines 4 months later waning against infection, I would have been like, no, these vaccines are going to have a lot more durability. It turned out that I had not really thought through how much the virus was going to evolve and how much it was going to go from alpha to delta to Omicron, and what the implications were going to be for vaccines. And if I had thought through that a bit better, I would have been a bit more circumspect in my messaging. I was too confident about the vaccines up front. So the point is, got a bunch of stuff wrong. I think it's going to be, if we're going to start rebuilding trust, it is about acknowledging and owning those mistakes. I think too many people in public health were way too cautious about schools and reopening schools. And I think that was calamitous in lots of ways. So I think some of that is going to be very, very important. And dealing with the bad actors who will kind of exploit this that is a different, harder problem. And then the last thing I'll say on this, whose job is it? trust is not really built by having Mandy Cohen, the CDC director, or me in my previous job going out and saying the right stuff. Much of it happens much more at the local level. And I always remind people that there are always opportunities for spreading good information, for building trust. And so that happens in the grocery stores. I find, like, my local grocery store, if someone comes up to me and starts talking about some public health issue, often COVID, like having very frank conversations with those people. If all of us can engage in that kind of stuff, anybody who's broadly in public health, I think over time we can get that trust back. But we have this idea that, like, if one person communicates more effectively or if one institution does better, none of this is to get at, like, CDC, fixing CDC is a generational challenge. That's also going to be important. But from a communication point of view, it is owning mistakes, engaging people much more broadly, and really that sort of distributed building trust over the long run.
Thank you. Naomi?
So thank you again for everything you said, and I broadly agreed with a lot of things. One thing that I kind of bristled at was you're saying that it's best to avoid jargon at all costs.
When talking to the public.
When talking to the public, right? And I definitely understand the benefit of that in the current moment for helping people understand and kind of communicating effectively. But when you think about it in the long term, something that strikes me is that you're kind of missing an opportunity to educate people for the next pandemic. You know, if in advance of COVID, people generally understood what RNA meant, maybe the RNA vaccine wouldn't have been as scary.
Yeah.
So how do you kind of weigh communicating in the present versus being equipped to communicate?
That's a good question. And when I say avoid jargon, I guess what I mean is avoid jargon without explaining it. So I talk about mRNA vaccines all the time. But depending now, it's a little bit, but like trying whenever possible to remind people that, like, all of us have RNA in our bodies. Like, RNA is the thing that DNA gets converted to. I'm not gonna, in most places, talk about the difference between messenger RNA and other types of RNA. But the point is that it's a way of reminding people that these are very natural processes that go on in our bodies. So I think jargon is fine as long as you use it as an opportunity to teach people. What I worry much more about is listening to a lot of experts who I'm following, but who are using terminology for shorthand for things without, and I know that most people have no idea what those words mean and aren't really following. So it's speaking much more plainly. But yeah, I agree with you. Like, use it as an opportunity to teach people that, like, mRNA is not some foreign substance that Moderna cooked up. It literally, I mean, again, this is where it gets funny, where places actually are trying to ban RNA. I'm like, how are you going to do that?
Exactly. Yeah.
Tell me what biological process you're going to use to stop.
And what will the result be?
And what will the result be? No living beings.
Excellent. Isabel?
Yes, thank you so much. So I was thinking about what you said when you were talking about your medical background, or your clinical background, I should
Yeah.
say, and how it grounds you in your experiences of talking about public health.
Yeah.
About public health. And I think that's an amazing point, and it's something I really think about a lot as someone who's not going to have a clinical career. And
Yeah.
try to kind of keep that
Yeah.
frame of reference in mind. And no disrespect to my family or whomever, but like a lot of them don't really care about public health, especially in a non-outbreak situation.
Yeah.
And so I was kind of curious, for people who don't have that clinical side or don't maybe see that, of course everyone sees public health on a daily basis, they might just not realize it,
Yeah.
but how would you go about increasing like empathy and support of non-outbreak public health issues in people who right now it's not the top of their lives?
Yeah, so a couple of thoughts. I mean, first, it's like, I think it's probably okay that it's not on top of most people. I mean, there's a part of me that's very sympathetic to just how much public health has been on people's minds. And everybody needs a break from it, right? So it's funny because at one point I was actually speaking to the president early in my time there, and I said to him, I said, if I do my job right, people will stop talking about COVID. And the reason that was important for him was he had a huge agenda. I mean, yes, he wanted to get COVID under control, but the president did not run just to get COVID under control, right? Like he had work we want to do on climate change, on building back manufacturing in America. He has a whole long list of things, none of which was going to get done unless COVID got under control. It's my way of saying that I think it's fine, first of all, for it to not be so front and center. But the second part is there are a set of issues that are very public healthy that people care deeply about. Lots and lots and lots of people have a connection to the opioid crisis that's going on. They have friends, they have family, they might have lost someone, they know somebody. That's a public health crisis. And reminding people that there are public health strategies and tools, that it's not just, clinical medicine, which is very powerful, it's great, is very much about like the diagnosis, treatment, prognosis kind of strategy. Public health takes much more of a population-based approach. That's really useful for lots of things people still care about. And so just reminding people that there are big public health, mental health. You can think of that as a purely clinical problem. We cannot clinically diagnose and treat our way out of the mental health crisis. So we have to take a public health strategy here. And almost everybody in America cares about mental health because almost everybody sees somebody struggling with mental health. So I think one way you could do it is take topics people care about and reconnect it to public health and remind them that public health brings a set of tools to those problems that are complementary to clinical medicine that will help move the ball forward.
Excellent. Arnav?
Yes, thank you, Dr. Jha. And you mentioned at one point how the reason that you kind of got into public health was because, you used the example of a homeless person being asked to take a pill 3 times a day. And you went on for a little bit about the structuring of the American healthcare system. Currently, what are the shortcomings that you see in the system and 10, 20, 30 years down the line? What are the changes that you would hope to see and how would you expect them to be brought about?
What are the shortcomings of the U.S. healthcare system? John, we got
exactly.
to wrap up by
Say,
midnight.
exactly,
Is that right?
exactly.
Was that what
Well,
we decided?
Yeah, exactly. We should all pack in for the evening.
Yeah, exactly. No. Look,
No, it's just,
so I've spent a lot of my time over the last 10 years studying other health systems and doing a lot of comparative health systems work, mostly with other high-income countries, a little bit with middle-income countries, but mostly with high-income countries. And let me maybe make 2 or 3 points that will then get to your question. Point number 1 is, there is a mental model that a lot of people have, I'm sure no one in this room does, that like, we have one system and Europe has another. The number of times people are like, why don't we do just what Europe does? I'm like, first of all, Europe is not a country.
right.
And second, what do you mean what Europe does? But it actually gets at a broader point, which is the UK system looks very different from the Swiss system, which looks pretty different from the German system, which is meaningfully different from the Australian system, which I realize is not in Europe, but and none of them quite look like the Canadian system. So lesson number 1 is there is no one health system that's the right system. And every country arrives at a slightly different system on its own, based on a variety of factors. Second point comes from, and is related, comes from a mentor of mine and a mentor of many, many generations of health policy experts. This absolutely brilliant health economist, probably one of the best of the last half century, passed away about 5 years ago, a guy named Uwe Reinhardt. And Uwe was like the James Madison professor at Princeton, brilliant guy, but also one of the funniest people
Yes.
you'd ever meet. And Uwe would always, like whenever I actually met him and chatted with him, like he would, make fun of me in some way or the other, but he was very like affectionate. But there's an Uwe line which I love, which I quote a lot, which captures a really important point about health policy. And then I'll get to your question. So in 2016, the senior senator, might have even been the junior senator from Vermont at the time, Bernie Sanders, because I think Patrick Leahy was more senior.
Yes, exactly.
But Bernie Sanders was running for president in 2016. Yep. And Bernie was out there and talking about how America should do what Denmark does. He's like, we should have the Danish health system because the Danish health system is great. And somebody asked Uwe, a journalist asked Uwe, what do you think about the Danish health system? Should America adopt the Danish health system? And in a very typical Uwe way, which I will not try to his German accent, which I will not replicate, because I'll get it wrong. He said, look, Denmark is great. I would happily take the Danish health system. But if you're going to want me to take the Danish health system, I will need the Danish political system, and it would surely help if you gave me the Danish people. And his point was, you cannot divorce health systems from the political systems that govern them, and you should not divorce health systems from the aspirations and narratives of the people they serve. Okay, that's a lot of stuff, so what does that mean for America? America has every health system you can think of. You want a single payer system? We got that. You want highly regulated places? We've got that. We have you want a state, look, Massachusetts is 20% bigger than Finland. The insured rate in Massachusetts is 98.5%, 99%. It's universal. Great hospitals, great doctors. We got a bit of everything in America. So that's a feature number one that we have to deal with, is that I just do not see any time in the near future a single uniform system for America. And I understand the advocacy for Medicare for all. I feel like we can't even fix Medicare for people over 65. Medicare for people over 65 is a huge problem. There are lots of challenges. If we can't fix it for that population, I have worries. And this is not a philosophical, I want government out of healthcare. I did not say that. It's just, it's very hard for us to have a single uniform system for a country this complex, this diverse. The other two quick answers. One is there are three big problems with quality problems that are probably not unique to America. We have access problems. 8-9% of Americans still don't have health insurance. That is unique to America. Our health system is insanely expensive. It's insanely expensive because our prices are crazy high. Same services, we pay 2-3 times more. Because we have highly non-competitive markets and we have weak price setters and not enough. So if you go the more conservative route, you have more market competition. If you go a more liberal route, you have more price controls and regulation. We have figured out how to do the worst of both worlds. So if you ask the question, what would I like to see? I'm actually pretty agnostic. I'd like to see some states, and they're going to be the blue states, play much more aggressively with price regulation. Treat these systems like monopolies, that they are, and just regulate the heck out of them in terms of prices. That will not work in Texas. So what I would say to my friends in Texas is build really competitive places, lower the barriers to entry, fight monopolies, enforce antitrust much more aggressively. Let's see a real capitalist system happening in Texas and see what happens there. So right now, in my mind, the problem is we're sort of stagnated into this morass. And because I feel like I live in a reality-based world, I don't have a prescription that I would be able to convince my governor in Massachusetts and Governor Abbott to do. And I don't know what prescription I would offer President Biden that he could do for the whole country. So I'd like to see a lot more experimentation with lots of different approaches.
Excellent. Leo?
Thank you for being here today, Dr. Jha. I want to say that your experience growing up as an immigrant here in the States really resonated with me. I grew up in Lubbock, Texas, but I was born in Taiwan. I moved to the United States when I was 3. And so growing up in a very conservative oil-producing area of the country, coming here and then getting into public health of all things has been a little bit of a... It's been a journey. A journey, yes. Yeah. And one thing that I wanted to ask was, with regards to the intersectionality of identities, you being both Indian and American, I was wondering how that plays out in your, how that played out and how that affected your work in the U.S. federal government, because you hear a lot about the issues with, or at least I've heard a lot about issues with dual loyalty. If you want to work in the State Department, if you want to work in the White House, if you want to work in any one of the areas that touches U.S. global health policy, there's this question. And how did that affect your time there, and what advice do you have for both?
It's a great question. Couple of things. it's very clear to me if you ask, like, yes, we have lots of complex identities. I'm an American. And if you ever want to feel like an American, walk into the White House. Like just walking into the office every single day, I was just reminded of what a remarkable country this was. That here was an immigrant kid, grew up poor, walking across the north lawn of the White House into the West Wing to go to his office. Like, that is insane. And so I felt deeply American. I've always felt deeply American. I never really struggled with so for me, I never struggled with where my loyalties were. I served a president that I believed in. I was part of an administration. I was part of a team. And the team wanted to get it right for the world, but the team was accountable to the people of the United States. That was clear. There were lots of policy questions and lots of COVID-related policy questions that came up around India. I was every bit as engaged on them as I was when it came up about China or it came up about any other country. And I don't think neither was I ever confused about what I was trying to accomplish. And nor did I ever feel anybody wonder, am I really on the side of Team America? No one ever questioned it. I never felt like anybody worried about it. Part of it was like my views were very consistent. Like if all of a sudden I was like, oh, with India, we don't have to do those things. Like people would be like, what are you doing? But that's just not what I would ever do. So I think there may be people who get tempted, but I think if you are very clear in your mission, you know who you're serving, you know what your goals are, I think most people understand that people have affection and love for lots of places, but that doesn't mean you forget who you're serving.
Skip, make sure we get everybody in class first. So Kayla, do you want to?
Absolutely. I really enjoyed hearing a bit more about your experience in evaluating the effectiveness of policy, and I was wondering if you could share more on how that experience has influenced policy making, how evaluating metric and thinking of metrics for success has influenced how you think about how policy should be designed. I think as someone who's tried to think about new methodologies for analyzing impact of international law, which is very challenging nowadays, would be really interested to hear not only about challenges you experienced on the metrics and evaluation side, but also how that's influenced your design thinking afterwards.
Let me try and answer that may not fully, and if it doesn't, just push back and then I'm happy to expand. So my experience before I went to the White House, then reinforced at the White House, is most policymakers want to get the answer right. And there's sometimes when they are constrained. The politics are such that we are going to do X. I get that. I'll give you an example right now at the White House. This president is deeply pro-union. There's just not going to be a lot of room for policy making that is going to piss off the unions. So if your policy prescription is do this and this, and yes, it'll piss off the unions, but it's the right thing to do, it's just not going to get a lot of oxygen inside the White House. And they just know that, right? I actually would use that in my favor. Okay, I would try to push policies where I thought unions could actually be really, right? So you have to understand the constraints, and that's the political constraints. And again, you can decide that's not good or it's in the ideal world, but I don't know. I don't live in, that's just the political economy. That's fine. President loves unions. Fine. Okay. But there's actually usually a lot of space still where you don't have that level of political constraint as a policymaker. And I found, again, that most policymakers want to get it right, and they're always looking for evidence to try to figure out what the right answer is. And where academics fail them is they bring up evidence 6 months after it would have been useful. They translate evidence in ways that are totally incomprehensible to policymakers. Or they give them advice that is beyond the capacity of what they can do. And what I started doing very early in my career is I spent a lot of time in Washington. Now, you guys have it easier because you're in Washington. And I would spend a lot of time with policymakers. And I spent a lot of time at CMS and other people in HHS trying to understand what are their constraints, what are the metrics they're looking for. If I thought they were looking at the wrong metrics, right? That was an opportunity for education. I would sit down with them and say, let me tell you about a different set of metrics that I think actually are probably a bit more useful for what you want. And sometimes I would win those arguments and sometimes I wouldn't. That's fine. And if you build those relationships over time, I found it would shape my research. I would try to write papers that there was a whole disconnect between when a paper is finished and when it's published. So I would send my papers off to policymakers well before it was published and say, I know you're working on this issue. This is going to come up in the legislation. Here's the results. It won't be public for another year, so don't put it out in public, but you can use it as you will. And so there are strategies you can use to really influence policy as an academic. Last point on this, when I was often at the White House, the White House is a crazy place. And the speed at which things happen are often very crazy. So something would happen at the border. We'd need to figure out our COVID policy at the border. And something would happen at 10 a.m. and we'd have a meeting at 3, and we would have to figure out a whole bunch of things in those 5 hours. And my team would be running around. And I just wanted to get a little bit of a scientific reality check. And I would call up a couple of scientific colleagues. And I'd pose a very narrowly tailored question. And some people would be like, that's really interesting. Let me pull together the evidence and get back to you in a week. And I'm like, I have 2 hours. And other people would say, either here's my first set of thoughts, or they'd say, can I have 30 minutes and can I text back some results to you? Great, take your 30 minutes. So part of it is also, and then those people who needed a week, I would just not call them again because I never have a week. So part of influencing policy as an academic is being one of those people who's willing to get outside their comfort zone. Of course, if I'm asking you a question and giving you 30 minutes, I don't want a comprehensive literature review, summary, pros and cons. I want you're a smart guy or woman, you know this evidence, give me your best guess. Because I'm trying to get it right, but my constraints are. So a lot of this is working with policymakers. They are trying to get the right answer and then figuring out how do you shape it based on the constraints that they have to live with.
This is among the reasons why everyone's writing briefing emails of 150 words or less, because you have to start to think about things compact, because you won't have time to read a paper.
No.
So, Ethan?
Yeah, I thought your conversation on effective communication was really interesting. I was kind of wondering if you, A, had an aha moment when you realized you had to frame issues in a certain way to reach certain populations, and B, how you think about people on social media, so to say, who have built their entire careers on communicating with a certain demographic and building an unparalleled rapport in the sense that everyone who watches them understands and accepts what they say, and how that relates to misinformation in terms of
A lot of complexity of very good questions, but complicated set of questions. I don't think I had an aha moment. I think I just got better over time, mostly because of feedback from my mother. My dad too. But they did watch because it was fun. Their son is on TV, so they're watching. And sometimes my mom would say, I didn't understand your answer to that question. I'm you didn't? I thought I was so clear. And then she'd say, oh, maybe it's just me. And I'm no, it's not just you. If you did not understand the answer to my question, I'm guessing most people didn't understand it. And I would go back and look at that, think about what was the answer. So that, I think, is really important. What's the point? Not my mother, it's feedback. And it's someone who's willing to give you honest feedback. And not just be oh, you were great, you were wonderful. My mom would say that too because she's my mom, and she'd be you were so good, and you look good. You look tired, by the way. What about the bags under the eyes? And I'm Mom, it's been a long pandemic. But the point is, you need that. Social media is interesting. I still spend some amount of time on social media, less than I used to, and I'm primarily thinking about Twitter, X, as it were. I'm always reminded, somebody told me this, which was, at one point in the pandemic, I don't know, I have on X, I have maybe 300,000 or so followers. A good number, but not a crazy number. And I'm just gonna be honest, I was bemoaning the fact that there was a guy who just is so bad at spreading bad information. And he has like 3 times as many followers as I do. So I was talking to a colleague and I was bemoaning this. And she said, do you know that the New York Post has a circulation 3 times bigger than the New York Times? I didn't know that. Tabloids always have much bigger circulations than mainstream newspapers. And she's like, you just have to decide. Do you want to be a tabloid? Or do you want to be like the Washington Post? And I'm like, I actually would rather be a Washington Post, New York Times than a New York Post or whatever. It's not picking up, but you get the point. Sensationalism always sells more. When you decide you're not going to be the sensationalist, you're going to have fewer friends. You're going to have just less attention. And in public health, there is a cost to that because more eyeballs may mean more people will misunderstand things. And especially now that X has gotten so polarized and it's become such a cesspool in many ways. It's just like yesterday, somebody tweets, because I think it's funny. Can I take 30 seconds?
Please.
So yesterday, somebody tweets. Let's see if I can pull it up. Yes. This random journalist tweets, Travis Kelce. You guys all know Travis Kelce. Vaccinated and heading to the Super Bowl. Aaron Rodgers, not vaccinated, hurt 4 plays into the season. It's a joke, right? Like, we're all goofing around. So I quote tweet that, and I say, I've said it before and I'll say it again. These COVID vaccines really are amazing. With a little smiley face. Like, this is a little light humor. We're in our 5th year in the pandemic. 90% of people liked it, enjoyed it, retweeted it, and then 10% of people lost their minds. And a small proportion of people were like, you're not calling for masking, what's wrong with you? You're killing people. And then some very crazy right-wing guys, including Clay Travis, who's got like millions of followers, is like, Biden's COVID guy making fun of Aaron Rodgers for his Achilles injury. What is wrong with these people? I'm like, first of all, do we really have to have sympathy for Aaron Rodgers? He's a millionaire. He's a football player. Yeah, I'm poking fun at the fact that he's unvaccinated. It's fine. Move on, people. So the point is that, and then that tweet became viral, and like that right-wing guy's tweet, and it was seen a lot more times than my original. My point is, virality is what's driving social media, and anger and polarization goes much more viral than like any effort. I mean, that for me, I was goofing around. Most of my tweets are not that. Most of my tweets are an attempt to try to explain something. It's just a different medium. For me, it's just like brand. What's the brand I want to have? And I want to have a brand of, I'm a pretty reasonable, middle-of-the-road guy. I'm clearly a Democrat. I'm a bit of a Biden Democrat. Like, I am a left of center. Get along fabulously with Bernie, by the way. We're very close. I got very close to him, but I'm not a Bernie Democrat. I'm very close to a lot of Republicans. I try to be pretty bipartisan on issues. And that means that, like, in a highly polarized world, I'm not going to be so popular. That's fine. You just have to decide what your brand is on social media and live with that brand. And with that brand comes a lot of upside and a lot of downside. Upside is you get someone like John Monahan to invite you to his class. Downside is you get a lot more harassment on social media.
Well, and you didn't reference Taylor Swift, so you would have gotten into a whole nother line with Kelce.
Exactly.
So here's what why don't we take the 2 folks we have here in the room, but I'm going to ask Mary if you could queue up a couple questions from Zoom, and then we'll bring it to a close. So please, do you want, please.
Thank you, Dr. Thank you so much for the talk. I really learned a lot from your speech. And I was hoping to get your view on something, I guess, beyond just the U.S. domestic health system, to look at the implication of public health for refugees and for really regular migrants. Because I definitely see there's a tension between domestic and national interest versus when we have individuals who doesn't necessarily have the privileges or the rights associated with a American citizenship. And I do think that ties into identity, but also into the kind of generational social mobility, including access to not just healthcare and medication, but also to educated literacy, which underpins a lot of those later income level and mobility and success. So I think my question for you is, I understand there's a lack of political appetite for providing more funds, providing those kind of social services to individuals who have been crossing the border. But what do you think is the responsibility of the US government, and what is sort of the US obligation facing the world, facing just humanity in general, that should be, I guess, discussed a little bit more or be paid a bit more attention to from your experience, like based on your experience?
So, couple of thoughts, and not like a deep area of expertise for me. So I'm gonna share what I know and then not speculate about stuff I know less well. Just if we were all here in 2019, just before the pandemic hit, one of the things I would say to you, and right now the numbers have gotten a bit more mixed because of the pandemic. It's harder to count some of this stuff. I would have said we have more people displaced right now than at any time since World War II. That was pre-pandemic.
All right.
And that number and I think that number is even truer today. And I have every reason to believe that will accelerate in the 5 to 10 years, 20 years that are coming. And there's a lot of stuff driving that displacement. Climate change is definitely one of them, but there's a whole set of factors. So I start there because it's a way of reminding ourselves that the problem that you're raising is not an isolated or a trivial problem. It is one of the kind of major problems of global public health that we have not dealt with. The second is that people who are displaced, internally displaced, externally displaced, refugees, others, and some of these are legal issues of what is a refugee, what are not. I have zero expertise here. There are people who actually know more about it. So I'm just going to talk about displaced people more broadly. They face a whole set of different health threats. And I would say as a global public health community, we have not done enough work to understand the unique vulnerabilities they have, the unique health threats they face, and how we meet their health needs. Like that feels to me like an entire field of global public health that requires like thousands of researchers and policy people. There are some people who work on that, but that number is tiny given how big the problem is. So it's a very complicated problem that we do not understand very well. Third, and now I'm going to talk about more of a moral statement. I believe we all, like as a global community, have a moral obligation to take care of people when they're displaced, when they're sick, when they're, and okay, so that's a great moral. How do you operationalize that? How do you hold people accountable? What does that mean? Does that mean if somebody is like dying in front of you, you provide basic aid? Yes. Does that mean you have a moral obligation to provide cancer care for, like, so there's just a lot of complicated questions that we have not worked through. On the border in the US, I've not paid as much attention, not because it's not really important, but on what's happening on the health side of things. But I guess the bigger picture point is, this is part of a broader set of trends that we really have to do more work. And again, I always begin with what else should the public health community be doing? And to me, I think we have neglected this as a broader issue that we've got to study, understand, and put policies towards.
I absolutely agree. Oliver, do you want to say something before we look?
Yeah. One of the things that came out of the story of your career today, but also your analysis of COVID and public health, was this intersection between politics and public health and kind of how the two fit together.
Yes.
And I was just, we have these global public health seminars every week in this room actually with Rebecca Katz, and others, and it's been a constant theme actually of a lot of our seminars has been this uncomfortable intersection. And I want to ask,
is it uncomfortable?
Well, I think because it's unclear where the handoff is sometimes perhaps. And so this was my question actually was, well, where is that handoff between the two? I'll give you an example. Our health minister of Britain has a big COVID inquiry in Britain at the moment.
Yes.
So unlike a lot of other countries, a lot of people's WhatsApp messages and prime ministers, are all being made public, and there's this judicial-led inquiry, and so we're discovering a lot of what was actually going on in some of these conversations. And one of the things the health minister at the time, Matt Hancock, said is he thought he should have been the one to decide who doctors gave care to and who doctors didn't at the hospital level. How should the triaging process have worked? Because he said ultimately, I think that's a national decision that elected officials should have made, and it shouldn't have been down to the doctors. And the medical community went nuts and said, absolutely not. This is not a question for, you know. And so I wonder on two levels. One of which is it clear enough at the moment in academic public health, but also the public health practice, kind of where the handoff happens between these are technical issues, and actually these are now issues, as you said, of prioritization and trade-offs, where our job is to give the best advice we can to elected officials about the science, and they make that decision. But then, as you said, I then have to play the decision that's been made and implement that. You know, so as a public health community, have we kind of defined that framework? But also when we think about this generation of emerging public health practitioners in terms of what we're teaching at universities in public health. And I worked a lot in Sierra Leone during the Ebola outbreak, and there was a massive US CDC deployment to Sierra Leone, and there were some incredible epidemiologists who came out who really struggled because they realized most of their job wasn't crunching numbers, it was the intersection with communities and trust. And he said, we really need to go back and reimagine public health training to prepare people better for this. But that was 5 years ago. And I think my question is partly around, you know, the training at Georgetown, at Brown, and other places. How do we prepare people for that intersection, and also with their own kind of emotional preparedness as well as technical preparedness?
Yeah. These are all very easy questions.
I know, that's why we brought you here, because
Straightforward.
exactly, you know, we knew you would have the answers to all of these.
No,
These are the perennial questions.
These are hard questions. So a couple of reflections maybe, and I'll talk a little bit about how I've thought about this a bit at Brown. First is to go back to that Uwe Reinhardt quote. It would surely help if you gave me the Danish people, but you need to give me the Danish government, right? Is that we do not teach people about the political economy of health. Like, you cannot just wave a magic wand and have the magical public health system or the healthcare system. First of all, there is no such thing. Right. And second, it absolutely has to be contextualized within the political economy of what is possible. And that is actually, again, I want to say it's okay, it's appropriate. I think this is the part my friends in public health struggle with, is they're like, it's politics getting into public health. And I'm like, public health is deeply political. You want political actions by political actors. And if you want to dictate it to them, it doesn't work because they're the elected officials and you're not. Now, to your question a bit more specifically, you know, when in the height of the pandemic, I, as a public health, not even an official, I was just an academic. I was like a, random free agent, giving advice that you should shut down bars in a place that has huge economic implications. Certainly has for everybody who works in those bars. Certainly for that entire economy. That is a decision that I feel very strongly a political leader needs to make. Like, I don't think the health commissioner of that state should have had the ability to make that decision. When you have large political implications. Now, I wish the governor had listened to me, but the point is, there's some things where I think it makes a lot of sense for political leaders. When you get more specifically into what is a traditional function of the public health space, I think political leaders should step back and give their public health people a lot more space. You know, to your question about who should have been making a decision, Matt Hancock's thing about, that's a hard one. My general inclination is that you want to, the problem of letting doctors decide is you want as much transparency and openness into that system as possible. What you don't want is doctors' individual biases, like Mrs. Jones probably not going to make it, so I'm not going to give it to her, right? Because that's way too capricious a system. So you want a system that has some openness, some transparency, some accountability, and then you want to let providers, physicians implement that. So I think there's some carving out to do here that says in a crisis, if it's going to have broad societal implications, it's got to be done a lot more with political leaders. If it's squarely inside the space of public health, political leaders should give their public health people that they have chosen a lot more running room and not micromanage it. But it all fits within a broader like political economy of what is possible. One last thing I was thinking about recently, one of my closest colleagues has been spearheading a whole bunch of efforts around safe injection sites. Talk about things that have complex political economy. And he's a big believer, and he's had papers in the Lancet and other major journals that show that you can reduce deaths, not increase use. These are sites where people can go shoot up. And I think that it's great that he's now trying this out in several states, but you can guess what the political climate of those states are and where it's not going to happen. So I think that's just the reality of this stuff. But, I would love to see governors, if the data really bears out on this, say to their public health people, I understand this might be politically unpopular, but it's going to save lives. I want you to do it. That will require political courage as well.
So maybe we'll take one question, Mary, because I think we're coming to the end. If you've got.
Yeah, one question reads, Dr. Jha, you've talked about the importance of public health and building trust at the local level and with communities. In the past, doctors were often seen as pillars of community, especially in the field of public health. Nowadays, that is not the case. Do you think that this is a role that doctors need to reprise once again?
Yeah, I would just expand it a little bit to go beyond physicians. I think physicians and nurses, pharmacists, it's interesting. Look, and I'm not trying to exclude any health profession. There are a lot of health professions that are very important. But those three particularly are ones that are very patient-facing, very people-facing. And people generally still really trust their physician. People love nurses, and thank God. I mean, nurses, what they do. But the group that gets, I think, the least attention or is the most underappreciated, because I think nurses are generally pretty well appreciated, and they should be, are pharmacists. Pharmacists do extraordinary work in the community. I will get back to your actual question, but I think we have underutilized pharmacists. They have a lot of knowledge. They're just an incredible workforce. All three of those, and probably other health professions, I think have a very big role in kind of rebuilding trust with the health system, rebuilding trust with health professionals. And I speak to a lot of physician groups, and one of my messages, and they'll often be like, you've done such a good job communicating, and I'm like, no. It just cannot be like me and Tony Fauci and Rochelle Walensky and Vivek and that is not building trust in America. It is every physician, every nurse, every pharmacist feeling like it's part of their responsibility to rebuild trust in the health system, the process, knowing that we're going to get some stuff wrong. We're not perfect. But I do think there is a very big role for health providers more broadly.
I would just add, for students, wherever path you're going to take, if it's in public health, it's a role for everybody.
That's true. And it goes beyond healthcare providers to health professions more broadly, public health people more broadly.
Well, we have had an incredible evening of conversation. I want to thank you so much.
It was my pleasure.
I would like everyone to give us a round of applause.
Thank you.